expecting it to last 30 to 40 minutes of presentation, and then you'll have approximately 10 minutes for questions at the end. We'll try to keep the content primary care focused. And then just a sentence that I've got to say, which is a bit of a tongue twister. The content of this presentation is our presenter's interpretation of the present guidance and best practice. It's accurate and up to date to the best of their knowledge. However, it's your responsibility to check the most up-to-date guidance before relying on the information in this webinar alone, as it may change over time and vary by location. Sorry about that. And then our ask of you is that please may you mute your microphone just to reduce the amount of feedback that we receive. And if you have any questions, as you have the question, please would you pop it on the chat. If you could type it into the chat, then we'll put it to our presenter at the end. And then we'll have a survey at the end as well, just asking for some feedback about this webinar and about how can we improve the experience for you and what you'd like in the ongoing webinar programme that we're developing. All right, then at that point, I'll hand over to Dr. Sharma, if you don't mind. Are you able to unmute yourself, Dr. Sharma? There you go.
Yeah, thanks, Dr. Caghill. I'll need you to help me with the slides. And at the end of 20-25 minutes, if you just interrupt me as well, because I have a habit of overshooting something.
No problem.
Okay. Thank you. Thanks, colleagues. And I spoke to you, I think, most of you a fortnight ago. So I'm the Associate Medical Director at Wigan, Bolton and GM for the Northwest Boroughs. Last time we talked about the clinical risk assessment and issues thereof and what helps. So this was a follow-up to that about managing the risk to self in primary care. Again, this is not an exhaustive presentation. There are things which will be limited by time. In a nutshell, suicide prevention is everyone's business, and it requires all systems to work very closely to do justice to it. So I'll touch upon that, about the system response. Next slide, please. So the background, I think, most of us are well aware. Fine. Self-harm remains the strongest factor, and it is true for both self-harm and suicide that it is linked to frequent GP consultation, and also if there is non-engagement by the patient who has a reasonable record of engagement in the past. So both too frequent attendances or none, both are a worrying point with regards to the risk of both suicide and self-harm. Next, please. Well, this is just to do a basic of clinical skills that we look at formulation, and therefore, because we touched upon it the last time, it's essentially looking at the problem, looking at the predisposing factors, precipitating factors, protective factors, and perpetuating factors. What essentially means is the care involved is identifying the vulnerability of the individual, intervention at the just if possible, or at the time of crisis, and then ongoing treatment to address the perpetuating factors. So it's not a cross-sectional intervention with regards to crisis or suicide risk. Next slide, please. So essentials are the same. Self-harm is the strongest risk factor, and we need to be particularly alert to patients with previous self-harm behavior, multiple comorbidities, mental health problems, and addictive behaviors. And yes, even though the age group of 45 to 59 is the most men is the most significant vulnerable age group, but we know the suicide rates have gone up in the aged 75 and above and 85 and above, and also that the young women less than 25, 18, 25 who present with eating disorder, personality disorder, and substance misuse. Recently, the trend is increasing there as well. Next slide. One of the things is that this regulatory or the standard guidelines do not do justice to the role of primary care, and little is said in them. To be truthful, the NICE itself recognizes they have to update this guideline. When they reviewed it 2 years back, they updated it, that it needs to be updated as soon as possible, because I think so it was in 2011 that these guidelines came out. Yeah, next slide. Yes, the NICE quality standard on suicide prevention that came about 2 to 3 years back, and it was released on the Suicide Prevention Day. It has 2 standards which are particularly relevant to the primary care, and that is for all adults presenting with suicidal thoughts or plans. It's good to involve the carers and also make them aware of the limits of the confidentiality. So I briefly touched upon last time as well that yes, we have to share the risk and we have to gather the risk information to do justice to this cohort of patients. And then is the issue about postvention, that people bereaved or affected by suspected or confirmed suicide are given information and offered tailored support. Each suicide has a huge toll on the family, the carers, and the immediate support system, and research varies 16 to 30 or 25 is the increased probability of self-harm and suicide in the carers. That number of individuals might be going down that line if not offered support. And it's again, there are our voluntary care sector organizations which do a brilliant job, but it also is our responsibility and across the system, because we lose service users who are with us and we also lose who are not with us. Yeah, next slide, please. In 2019, NICE has published advice on optimizing medicines and reducing access to medicine as parts of your guidance on suicide prevention. So this is the one which was about suicide prevention in the community and in the prison population. And it talks about multi-system coordinated approach to suicide prevention at the systemic level, local system level, as well as the regional, national. So for relevant to us is it talks about restricting availability of medicines for purchase, prescription, and in the home, reducing stockpiling, and carrying out medication reviews. Now, there's enough evidence that reducing access to means is a viable intervention with regards to self-harm and suicide prevention. And that needs to be factored in even from when we look at safe netting in the community. And the professional teams, be it crisis team or others, they are not a substitute for safe netting for the patient within their support system. And in a review of, the crisis teams and everything are married to the core fidelity model. And in a review by patients who are with the mental health services or otherwise, they do value the medication reviews. What they don't value is when the contacts are overtaken as just for dispensation of medication or medication supervision. So if their contact with their care providers, especially the professionals, limited to just medication issues, that is not helpful to them. But the opportunity for rationalization medication reviews, they all welcome it. Next slide, please. Yes, there are general principles in the NICE guidance on the long-term management of self-harm and suicide prevention. And these do touch upon the good practices that should be there. So few pointers, again, the list is not exhaustive, is about offering the individuals who present with self-harm with the relevant written and verbal information, which looks at what are the dangers and adverse outcomes with self-harm, the available interventions and possible strategies available to help or reduce the health self-harm or its consequences. So depending on the modality of self-harm, the acute intervention varies. If it is self-poisoning, which remains a very common method, then it is on occasions difficult to ascertain the exact amount. There could be and if we cannot, if there is a suspicion of what the exact amount is, then it is better to err towards the urgent care side and get where they can have levels of the agent, they can look at accordingly for immediate interventions. And if it is like self-harm by other methods which do lend themselves to harm reduction, then harm reduction approaches with regards to superficial cutting and they come into play. And yes, we have touched briefly, treating of any associated mental health conditions remains a priority. Next one. We cannot overemphasize that we share quite a large cohort of patients who are with the mental health services who will come into the urgent care with self-harm or suicide. And there it is about joint working, collaborative working, as well as having open lines of communication, ongoing lines of communication. And the NHS systems, unfortunately, because of the pressures, do frequently fall apart on this. Because the communication is usually by written documents, usually in summary reports, prone to delays, prone to delay in the SIP flow, prone to delay in follow through, and there's no ongoing contemporaneous communication going on. And last time also we talked about that the risk of suicide and self-harm behavior is a dynamic one as well, and it keeps changing. So immediate post-discharge care as well as ongoing care when different professionals are involved, that is of prime importance. So yes, if we are looking at suspected suicide attempt or self-harm which is not likely to amend itself to immediate intervention at the primary care, then referral should be considered. And these are what NICE says is if there's a level of distress that is rising, high or sustained, or the risk of self-harm is escalating, and also if the levels of distress to the carers is escalating, then to prioritize the referral. Next slide, please. This is again emphasizing through the NICE guidance as well, the joint working and effective communication for all individuals who are with primary care and secondary care. And then also the social professionals, our social care professionals, we all need to be there on the table. And previously and currently also the mode was CPA meetings, but we all know that the CPA usually are confined to the mental health services. Now going forward in the community mental health review framework, CPA is being replaced by individualized and personalized care plans. And the idea is they are again, the aspiration is for them to be collaboratively produced in the first instance and have all the major players. So going forward, that is a major review of providing community mental health care. And then is the post-discharge care. In that we also, expect our primary care colleagues to monitor the physical health consequences and ongoing physical health monitoring for patients who self-harm and are likely to self-harm. Next slide, please. The other source is National Confidential Inquiry into Suicide and Homicide, and they also extend safety in mental health. And they have a safer prescribing toolkit, and there are enough resources. We have toolkits, risk assessment toolkit by the NKISH as well. And this encourages the safer prescribing of opioids, ensuring that there is a service in place for people with complex depression. And that is one thing that I think so we need to look closely at managing complex depression, because unfortunately this cohort of patients might fall through the gaps between primary care and secondary care. Classically, the community mental health teams have been ordained towards severe mental illnesses. And this is again the post-vention. Next slide, please. So this is research which encapsulated perhaps 10 years of data, and it is a comprehensive data review of the risk of self-harm and suicide within the primary care. And 10% patients were prescribed psychotropic medication, but no psychiatric diagnosis. And we were still using tricyclic antidepressants with patients who were presented with self-harm or overdosages. And yes, the inverse care law is that if the practice is in deprived areas, there's lower likelihood of patients being referred to the next level of care. Yeah. Next slide, please, because these are what I touched upon. This is a paper which was published recently this year, in the early part of this year. And this looks at the role of GP in management of self-harm in primary care. And it does a systemic review of the studies. And it says that, some GPs attain some knowledge of managing as such through training and teaching. Others find it to be challenging. And the challenge is well recognized within our colleagues' primary care population about identifying the suicidal intent. And that's not only about the competencies or skill mix of our primary care colleagues. It's also about the confidence in this local healthcare system, including the secondary care. Because if they don't have the confidence in ongoing care being provided or clear-cut referral routes, then they are wary of opening a set of clinical variables where they don't feel supported subsequently. Next slide, please. So these are the barriers identified in that, and this also had a qualitative review with significant number of our GP colleagues. So the systemic factors are the workload of the GP colleagues, access to mental health services. The assessment itself we touched upon last time about the time available and confidence, which is affected by GP assessment. We've talked about the feeling of unpreparedness and lack of specialist knowledge, then the service provision itself, and also the long waiting times on clinic letters, as well as for effective interventions if we look at psychological interventions. Next slide, please. The facilitating factors well recognized are GP training or primary care practitioners training, robust clinical guidelines which are collaboratively produced involving the mental health service users, improved communication lines, addressing the enhanced service provision in primary care for self-harm and suicide prevention, and also looking at the young people involving their family and carers in particular. Next slide, sorry. This is the Center for Mental Health, again, has provided a seminal paper in collaboration with Samaritans, and it's a very good resource for primary care suicide prevention, and it also provides direction for future travel. And there the bullet points are provision of effective ongoing training for primary practitioner colleagues, investment in the capacity of primary care services to enable longer appointments, again we touched last time, and emphasizing the continuity of cares for patients needing ongoing support, and yes, provision of emotional support for practitioners themselves. So though the language of GPs, but it's for all our primary care practitioners who are dealing with this. And it's not only suicide, otherwise the challenge with the pandemic, otherwise the challenges within the primary care, they do risk, and we know the GP workforce crisis, we know the burnout feeling down in the true to secondary care as well. So it's about empowering the system to enable these colleagues to have emotional support. And there are well-being programs which need to be refined further. And then effective care pathways, we have been there historically, but yes, they are well defined now, reasonably well defined as compared to previously, and improving the referral process and the 24/7 CRHT single crisis line, and then the care assessor pathway, which is NHS 111 number in future, that being the access line for patients with suicide or self-harm risk. So these are all the forward going, and some of them are already in place. Some of them will definitely be by the spring of 2021. Next slide, please. Similarly, it talks about supporting continuity of care, monitoring and follow-up of people, offering appointments with the same clinician. That is valued. We have talked about that, the therapeutic relationship, the therapeutic control, and the therapeutic alliance with the patient being most valued by service users over and above the risk assessments or the risk interventions being dictated to them. And also establishing practice-wide policies on suicide prevention and actively seeking contact. with at-risk patients to disengage. This touches upon the evidence that I talked about in the earlier slides, that not only frequent attenders, but the ones who disengage are at risk. Next slide, please. So if we look at what should be embedded in the policies and procedures, we talked about static risk factors last time and the past history. So there can be automated system for flagging those risk factors, the past history of self-harm, high suicidal intent, comorbid physical illness, or comorbid physical health conditions. So those risk factors or substance misuse history. Then yes, again, emphasizing the identification, treatment of management of depression. That is also one of the 10 cornerstone pillars of the current government strategy promoted through the Royal College, but also the NKISH for suicide prevention, and it has been taken up by all STPs. Additional measures for high risk populations. We have talked about that men generally do not access any services, be it primary care, be it secondary care, and then looking at those high risk populations, which are the transition of the population, which is truck drivers and those occupations where we know substance misuse is there, where we know who will never be able to reach to the current configuration of services, they've never accessed them. And then emphasis on safety planning and safer prescribing. And that document I would request is a very good resource. It touches upon in its appendices how you can have a very coherent and meaningful safety plan, collaboratively developed. What are the core elements of it? And that can be developed across services, primary care, secondary care, and these need to be openly communicated between the services. And that is true for not only interfaces, but also intra-services. And that is where the voluntary care and the whole system approach comes in, because this care planning, safety planning involves the individual's care support, the family, the support systems, the voluntary care sector that they access or they can access, and then the system, how it can provide support. And that is where the system-wide approach most importantly can come together. Next slide, please. And yes, the emphasis is again on postvention, and this is the bereavement by suicide itself being a risk factor for suicide. And there are now again evidence-based interventions aimed at supporting people who have been directly affected by death by suicide. And I said the number can be very high, 16 to 30. And again, it's about having emotional support available and embedding this postvention across all services, and including the valuable support offered by the voluntary care sector organization, including primary care, including secondary care. So yes, we should have even specialist role are envisaged in certain STPs. Certain mental health services or primary care services have postvention officers who then try to bring together all these strands. Next slide, please. Further down the line would be, it's well recognized, even though the guidance framework through the NICE and other are not well developed or not well articulate on this role, primarily because they are nearly a decade old. But it is well recognized and now understood that the role of primary care is multidimensional, and that is frontline assessment, referral, and also ongoing support. And when we talk about frontline assessment, then we come back to the whole clinical scale communication about the risk assessment that we talked last time as well. And therefore, there's a need for acceptable ongoing, and I emphasize on the ongoing evidence-based self-harm and suicide prevention training for all the primary care colleagues that must be evaluated and should be cost effective. And also clinical guidelines and practice policies should be co-produced. So yes, there are national guidelines, there are regional variation of it, but also having robust local principles and percolating across uniformity and standardization in consonance with the guidelines so that the practice also is in consonance with that. And the primary care networks should develop and incorporate all the policies into wider suicide prevention strategies, which are well developed in the NICE 2019 guidance about prevention of suicide in the community, as well as in the prison population. Next slide, please. This is last slide. This is thanks to my, again, suicide prevention lead, Katie Donnelly, who helpfully helped with looking at what is available. And so it was quite a comprehensive. I've just picked up the elements which are relevant for primary care colleagues. And these are as I say, these are just suggestions, but this is out available here as well. 2 sort of training programs, and it also gives the cost and what they target. So the assist and the storm, they both have robust evidence, and storm is introduced in version 4. It was developed by Linda Gaskell and team, and primarily focuses on who was a champion of suicide prevention in primary care, and it focuses on rightfully on preventing suicide care or preventing suicide in primary care and the skills thereof. So the GP colleagues, pharmacists, all are the target audiences there. I think so. That's the end of my presentation, and I'm open to questions. Thank you.
Thank you so much for that. It was very interesting, and you ran perfectly to time. You didn't need me to let you know the time at all.
Thank you. Thanks,
so
Katie, for joining. So sorry, can I bring in Katie, as you know,
course,
she
yeah.
would want to touch upon the system of wide approach, as well as, you know, because she's actively involved in suicide prevention at the STP level, so she will give an info. Hi, Katie.
Hello, sorry, it says, hello, it says that I'm called Mia Donnelly. I'm sorry, I had trouble joining, so I've joined via my phone, which is my daughter's account. So it's lovely to get the opportunity to talk to you all. As Parveen says, I'm quite new in post as a suicide prevention lead for the trust, and I've been working with Parveen and colleagues across the Wigan borough to build on work that's already started. Thinking around suicide prevention, I agree with everything that's already been shared with you in terms of thinking as part of a system and how we can all work together to prevent suicide, not just one individual organisation working on their own, but how we can all connect together, open up the communication channels between and work together as part of the system to address suicide prevention. North West Borough is a part of the Greater Manchester suicide prevention approach, so we're absolutely committed to that strategy. I've been doing some work looking at the data for Wigan and looking at people who are known to North West boroughs who unfortunately take their life, and what lessons that we can learn to moving forward. A lot of the areas have already been touched on, but what we're seeing is a factor of dual diagnosis being a key issue, people struggling with substance misuse and their mental health, and it's how we can get services, primary care services and secondary mental health services to work better together to support those individuals.
Parveen mentioned in his talk about having a post, some areas having a was it a post-vention officer? Is that similar to your role at the moment, or?
So my role's trust-wide, supporting the trust to develop the suicide prevention strategy as a whole. So the trust suicide prevention strategy has got 4 pillars to it, one of which is post-vention and support for people bereaved by suicide. I noticed in the chat a colleague had asked a question around resources for people affected by suicide. I'm not sure whether colleagues are aware, but there is the Greater Manchester Bereavement Service, which includes suicide bereavement. We can share the link with people if you've not already got access to that service, but it's available across Greater Manchester. There's also a service that Papyrus lead, which is a debrief service. The good thing about the Papyrus service is it's for people affected by attempted suicide, as well as completed suicide. So it's got a broader remit, and it supports families, carers, professionals, because I think, as was mentioned within Parveen's talk as well, we've got to remember our own mental well-being and thinking of colleagues as well, haven't we? And Papyrus offer brings that. So yes, part of my role is around post-vention, but it's also prevention, safer care, making sure we've got the right information to inform our planning and working with partners.
Okay, thank you. I was wondering, if there were any more questions that anybody had after the talk that's just been given at all. I've had a couple myself as well, if you don't mind. One of my questions was around working, and you touched on it as well. Sorry, I keep wanting to call you Mia because it's written under where your face is, Kate. It was touched on about how important it is for primary and secondary care to work together, both in individual cases and on a, as you've been saying, on a system-wide approach as well. In the individual cases for patients who we've got who are under the mental health team, and obviously we're having contact with as well, how is the best way for us to communicate with each other? Because often they're having multiple frequent interventions, and how is it best to be on the same page, really, is one of my questions.
Thanks. So, sorry, Kate, you want to go or I can take it?
No, you go. I can add to Parveen.
Thank you. So we have been active investing in improved communication with the GP colleagues. So there are, as you're aware, or you may be aware, there is this primary care network consultation slots, which we have piloted on 2 occasions. And they are about 2 hours, full morning sessions on a couple of days in a week. And we have got our pharmacy colleagues, nurse practitioner, and I join them on a Tuesday morning as well. And we are happy for, I've said that because, to be truthful, the uptake hasn't been brilliant. There has been very positive feedback when our colleagues have contacted, and we have also addressed serious concerns which were raised in that, not for the Wigan services, but discharge from Bolton services, and then me and my associate clinical director met them. But I've said both the models are there, and I would want the GP colleagues to give the feedback. At the system level, it will be taken forward. I have asked for GP colleagues with interest in mental health, and if they're in Section 12 approved as well, but definitely with interest in mental health, they should be leading it from the primary care side, the engagement, and then we can refine, look at what are the optimum times to engage. And I have said that because this is a pilot, if that goes well with the engagement, my promise is that I'll take it to if need be, a specialty session. So you can have adult consultants coming in, one of them, old age camps, at a predetermined frequency. And we are happy to talk about all the cases open, or if there are simple discussions to be held on medication, everything is there. And with the idea that promotes collaborative working. The second is obviously this is an attempt in the webinars, and we can engage. We're happy to use this portal to look at systemic issues if they're identified. If most of my GP practices colleagues are facing certain particular issues with accessing services or otherwise, or let's say our services are experiencing with regards to shared care, or so they can be brought to, I would seek your support in that we can utilize this, because this is quite more frequent, and it's already well established. So we can have, on a well-defined systemic issue, we can get together here as well. The third strand that I am actively seeking support through the CCGs, it has gone to the clinical leadership team group once, but I need to follow it up, is what is the pillar stone in the NKISH, which is about managing depression in the primary care, and especially the complex depression. So that is what was the collaborative care model, which is in the NICE guidelines, which will be retained and emphasized in the new guidelines as and when they come out. So that is about having, as soon as my submission is, as soon as we have one failed trial of any antidepressant or one failed trial of TWB, the IACT services, the communication channels open with the secondary care and primary care between them. And then it becomes a outcome measured approach with an MDT setting of, it is resource intensive, with an MDT setting, depending on the severity and the complexity, including the secondary care practitioners, could be psychiatrist, could be nurse, could be psychologist, as well as the GP colleagues or the other practitioners, and having the outcomes reviewed at predetermined fortnightly or this. So it's perhaps going back to the KH register model, but identifying the complexity or difficult to treat depression because of their very clear link with suicide right at the beginning in the primary care, and this virtual way of interaction, it gives a real opportunity to get into that MDT meeting through virtual meetings rather than what were the previous constraints, because we were not into this. And we could use all portals, attend anywhere, we could get the patient involved in those discussions and everything. So that's but yes, I need support in that. So these two are already functional. Third, I'm trying to pursue, and I might come back to you for pilot studies.
Wonderful, thank you. The pilot studies, if you could give me the details, I can put them on the comments box so that the people present might be able to join. Yeah. Potentially.
Let me get it. Yeah, I'll come to you as well, and because I'm still in its fancy stage, it needs to be agreed at some level that the primary care networks will look. So that agreement is what I'm looking. But you say proof of pilot, definitely I'll put it forward if someone, because that might then refine what I want to say to the PCNs.
Yes.
Okay. Thank you.
There's also and I'm not sure how care are integrated. It's a new thing that I'm learning about, but the complex case management meetings that are being led by the local authorities and how much primary care are part of that. I know the mental health team, Dave Hickley's been working from the Wigan Borough, has been working with the local authority, and we are with you to look at some complex case management cases, particularly people who are struggling with the mental health and substance. I don't know how well primary care are connected into that infrastructure.
Thank you, Katie. Yes, because that's another avenue. It's a weekly meeting, to be truthful, on a Thursday afternoon, and it has all the multiple players. So which includes the Greater Manchester Police. We are with you, the housing, the complex dependency workers, and the clinicians from the secondary mental health care, including the matrons, quality matrons. But what it is currently, and also the AMPs, which are the force who deal with mental health act assessments and everything. But yes, we would welcome it to open it to GP colleagues as well for patients who are complex and open to services. So I think so. There's well, I don't think I know there's an email inbox or email inbox. Sorry, that's where it goes, which is dedicated to this, and it just needs 48 hours prior to that week's meeting. And then we can always, you can Skype in, you can do that. We'll come to the MS Teams in due course. So we're absolutely, that offer is open to refer in. And if they're open, then we will contact those relevant practitioners as well to look at the complexities. If it requires a multidisciplinary, if it is something to do with the team specific and we can have communication gaps. So that essentially I would say is pick up the phone. And that still remains. We will get back. It might not be the same day. It's same like with our primary care colleagues. We have to pick up the phone and discuss things. And Liz, me and you have had experience of, helping out one patient, definitely with a joint approach where the system had already made its decision to discharge the patient, perhaps, and then we got it back into where the patient should be. So yes, and that offer will keep improving once we have these channels open. So as I said, the personal communication will also improve if we get all these links, the webinars, the primary care network consultations, and the complex case. And Katie, am I right? There's also a multi-source or a multidisciplinary suicide group meeting within the outside of the secondary mental health, which is led by the council, and we have a suicide lead there as well. So from the social care side.
Yeah, it's that group. Yeah, the Wigan Suicide Prevention Group. And that's led by, it was led by public health colleagues, and it's now chaired by Rick Bolton, who's the safeguarding.
Yeah, so that's another avenue where, if they haven't traversed the mental health, or even if there are issues about, where the site is cared, where they're properly cared for, so that will be there.
Okay, so there's quite a lot of options available for us there. Is there a place where it's summed up the access to those particular meetings that we could possibly take a complex case that we were concerned about to? Is there how does the channel in work? for us.
So I'll take this as for me and Katie to do thing. Yes, so we'll create a communication document which has all the appropriate links. Brilliant. And let's say at least a brief description about what is on the offer.
Wonderful.
Thank you.
Yeah, that sounds great. Thank you. Thank you very much.
Robert, did you have a question?
Did anybody else
sorry,
have
I'm conscious that we've gone beyond our 10 minutes of questions, but for those who are happy to listen to my question, we all know that a symptom of depression is suicidal thoughts, and that may be something that goes through people's minds, and the risk assessment is much more complex of how far has that thought gone, their demographics, lots of factors go into that professional judgment. What I sometimes struggle to kind of get a feel for is when would patients benefit from being referred to secondary care, and when really, because I've had there are patients that I sometimes refer and I think you're not going to do anything different than I've done, but they're expressing suicidal ideations and things, and inevitably they come out with not very much different. But I wonder if I've got the balance right of, am I referring too many people? Am I choosing the wrong people? I wondered what your thoughts on who should be referred, and yes, more, it's probably better to say who should be referred.
Yeah. So essentially, we are all experienced clinicians, and if you're not, we get into that role with the supervision. So our gut feeling remains the best. If you are in doubt, do refer. Fine. So that still remains the other bit is, if we all know that suicide, we rely on suicide intent, but as we talked about the previous ones also, that the suicide act has many more components apart from the intent. So if we have, and nowadays, we talked about those feelings of, in the acute episode, if there's a feeling of helplessness, or there is feeling of entrapment, overwhelmed with the life, or if there is agitation, anxiety, insomnia. So there are dynamic factors which are there. And if you're not sure of the safety netting, that's another thing, And if you're not sure of your therapeutic alliance, and if you're not sure whether the patient is coming forward at all. We talked about what the suicide intent is. If we have gone through the stated intent, and if you've gone through what is termed as reflected intent, where we enable them to reflect on what went into that suicide attempt or planning. So after that reflection, if we still don't have enough information for us to be comfortable, then I would, and if there's a lack of safety netting, and apart from all the complex patients which we know with a past history is a very robust indicator. If there have been history of past self-harm which have escalated to the secondary care, what was the care likely? What was the care requirements in the past for them? And again, we know the patient population which is overrepresented. The dual diagnosis patients, we need to have a high index of suspicion, because it's not only the intended but accidental suicide which goes in. And so there's no one single answer to this. No, so it's the clinical intuition. It's the clinical intuition. But the emerging evidence of more variables coming into that assessment, and also what can you formulate as a safety net and a safety plan. And if you're not comfortable with it, apart from the clear-cut things, if there's an immediate plan, if there is no safety netting at all, and if there's a serious mental illness, command hallucinations, or a very definitive immediate plan intent, so those we automatically escalate to the urgent care. Fine. And if you see that you have dealt with it on 1 or 2 occasions, there's not really difference. Fine. So the self-harm is also continuing, it's perpetuating, and it's not. So whatever the offer you've tried the initial, and there's no engagement, no offer to buy in. It's better to escalate.
Yeah.
Thank you.
Thank you.
Hopefully, I've answered the question in part at least.
Yeah.
Thank you.
Thank you very much, and thank you for joining us. Thank you to the audience as well. If you have a look in the comments box, we're going to put a questionnaire. If you'd like us to send you a certificate of attendance, a proof of attendance, then please just include your email in with the comments on the questionnaire about the session. And likewise, if you've got any specific ideas about what kinds of webinars you would find useful, then let us know as part of your feedback if you don't mind, please. Thank you very much.
Thank you. Thanks for your time.
Thank you. Thanks for coming.